We're back doing some Uworld questions. I'm also having lunch right now, so let's do it. Okay, 220 internal medicine. "68-year-old man comes to the office with a 2-day history. Right foot pain and swelling. Okay. The pain started acutely when he awoke in the morning. Initially, the patient had pain only on dorsiflexion of the foot, but he progressively developed pain with. Okay. So the cartilage is calcified. This could be pseudogout. You get chondrocalcinosis in pseudogout. It's not septic arthritis. You'd be like warm, be febrile. Oh, interesting. This is pseudogout, yeah. Pseudogout. So it's typically in the elderly. Monoarticular and chondrocalcinosis. Hey, this is like the key. This chondrocalcinosis. I'll keep these cards. Fantastic. Oh, there's someone in here. What's going on? Whoever that is. John, thank you for joining us. Let's do some. Oh, you're gone. This is transient. All right, let's keep going. So we have a 56-year-old man comes to the office for follow-up. Type 2 diabetes mellitus of 15 years duration, hypertension, hyperlipidemia. So all these risk factors. His diabetes mellitus currently managed with metformin, glimepiride. I forgot what that is. Hemoglobin A1C is 8.5%. Switching to insulin therapy to attain better glycemic control is discussed with the patient. Achieving a goal of 6.5% with the use of insulin is most likely to reduce the risk of which of the following complications over the next 5 years. Hypoglycemia not really the thing here. I mean, this guy just has high sugars. This is an A1C at 8.5. MI makes sense. I mean, all these factors put this person at increased risk of MI. That's directly correlated with diabetes. Retinopathy, I mean, sure, but stroke, yes. I think it's MI, bro. It's retinopathy. Wow. So why is it not? I mean, we were considering myocardial infarction. Why is it not? These trials suggest that intensive glycemic control does not reduce macrovascular complications like stroke or myocardial infarction or all-cause mortality. Strict glycemic control with insulin is also associated with significantly increased risk of hypoglycemia. Interesting. Furthermore, the core trials showed that very intensive increased glycemic targets appear to increase risk of all-cause and cardiac mortality. What? That's so interesting. Major randomized uncontrolled trials like the UKPDS trial and the Accord trial suggest that intensive glycemic control, so hemoglobin A1C between 6 and 7% with insulin and or sulfonylurias, significantly improves mitorovascular endpoints such as retinopathy and nephropathy, so microvascular complications. But macrovascular complications actually are not reduced by this intense glycemic control. Same, and actually adding more intense glycemic control increases the risk of hypoglycemia, which makes sense. Type blood pressure individual like to increase the decreased risk of microvascular complications. Okay. Let's keep going here. So we have 34-year-old man comes to the office due to 2 weeks of fever. So 2 weeks, fever, dry cough, fatigue. He has a history of allergic rhinitis and uses nasal glucocorticoid daily. The patient works in a clinic that evaluates patients before and after organ transplantation. He lives in Arizona and recently returned from a trip to Central America where he and his wife hiked and explored caves with prehistoric drawings. This is bad. I mean, this is just really talking about like maybe a histoplasma or something like that. They have 2 pets at home. Also, another thing could be hypersensitivity pneumonitis. Now he's febrile. Molluscid crackles, febrile crackles, alveolar opacities with hilar lymphadenopathy. This is more histoplasma with this hilar lymphadenopathy. Granulomas, yep, with yeast, so it's a fungus. Which of the following is the most likely risk factor for this patient's current condition? It's where he traveled. He went to these caves with prehistoric drawings. It's not coccidioidomycosis because that usually has like a different presentation. It's not like consistent with this granuloma. Granulomas is histoplasma, right? Yeah. No, medication use, not really. Pet exposure. I mean, I think it's the recreational activity. So let's see, why is it not coccidioidomycosis? Because that's what that's suggesting. Okay. Dimorphic fungus common in the desert portion of the southwestern United States. Although symptomatic infection is often marked by subacute pulmonary symptoms, chest X-ray usually reveals a unilateral, not bilateral infiltrate with ipsilateral lymphadenopathy. Spherules with endospores, not yeast. See, we got to make a card about this because this has been a while since I reviewed these coccidioidomycoses. Recent cave exploring suggests infection with Histoplasma capsulatum, a dimorphic fungus endemic to temperate areas of the United States, Asia, Africa, and South Central America. Because Histoplasma capsulatum proliferates most readily in soil contaminated with bat or bird droppings, patients often have a history of vocational or recreational activities that increase the risk of exposure. Small dose inoculation, rarely under 5%, causes illness, but patients who inhale larger doses are high risk for symptomatic infection. Manifestation usually begin 2 to 4 weeks. Subacute fever, malaise, dry cough. Without intervention, they resolve. Yeah, cool. Cool. Let's keep going. 27-year-old woman comes to the office due to intermittent episodes of palpitations and dyspnea on exertion. Okay, so she has some palpitations, some dyspnea on exertion. Could be a lot of things. Blood pressure is relatively normal. On examination, there's no peripheral edema or jugular vein distension. The lungs are clear to auscultation. And she has a 3 out of 6 ejection type systolic murmur heard along the left sternal border, so more like aortic root, and decreases in intensity when the patient moves from a standing to a squatting position. Decrease in intensity when the patient moves from a standing to a squatting position. So it decreases with increased preload, which is what you achieve with squatting. Are we saying this is infective endocarditis? I don't think so. I really don't think so. Medication use. Yeah. Like cocaine or something like that? No. Occupation? I think this could be Hockham. A very young person. There's some palpitation, some dyspnea on exertion. So most likely family history. I'm going to go with that. Yeah. Almost. This patient with palpitations, dyspnea, and a 3 out of 6 systolic murmur that decreases in intensity with maneuvers that increase left ventricular blood volume, such as squatting, most likely has hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy typically involves enlargement of the interventricular septum, which can cause dynamic left ventricular outflow tract obstruction, LVAD obstruction, that leads to exertional symptoms. Harcum is the most common inherited cardiomyopathy in the United States. It is inherited in an autosomal dominant fashion, with roughly half of the cases resulting from an identified mutation in genes encoding for myocardial contractile proteins of the cardiac sarcomere. Cardiac myosin binding protein C and cardiac beta myosin heavy chain are most commonly affected, accounting for approximately 40 to 30% of identifiable mutations, respectively. The phenotypic manifestations of the disease. Okay. How come? I mean, that's very, very, very rare, but we'll keep it 26. Fantastic. We identified Holcomb. Let's keep going. So now we have a 56-year-old woman comes to the emergency department due to a week of fever, dyspnea, cough, productive, foul smelling. So this could be a pneumonia. No chills or rigors. Patient was seen at an urgent care for these symptoms 4 days ago, and a 5-day course of azithromycin was prescribed to treat pneumonia. So they treated for her like community-acquired pneumonia, maybe a walking pneumonia here. However, she feels worse despite taking the medicine, so it didn't work. The patient underwent upper gastrointestinal endoscopy 10 days ago. Long history of heartburn. So she went, okay. And now she's febrile, tachycardic. Dentition is poor. Poor dentition with a recent GI procedure. Crackles are heard over the right upper lung field, so there's something going on there. It's leukocytosis. Right upper lobe infiltrate. So, I mean, if we're thinking about like a GI procedure with poor dentition, she definitely has pneumonia. Huh. A fluoroquinolone, doxycycline, metro. Like, this would be like an anaerobe. Amoxicillin clavulinate. Ciprofloxacin. Man, this is tough. See, I don't think it's metronidazole because that's usually infections below the diaphragm, so no. Bactrim, GI, like E. coli or something like that. She has like an aspiration. It's possible that it could have been an aspiration. She probably had an aspiration. What's the best treatment for aspiration? I mean, you want something that covers like Klebsiella or... Honestly, I have a feel. I don't know why, but I have a feeling it's amylclavulinate because that's usually what you get for like these weird like aspiration bacteria. Yeah. Oh, beast. Let's go. This patient underwent upper gastrointestinal endoscopy. Okay. And subsequently developed community-acquired pneumonia, likely due to a bacterial aspiration during the procedure. Upper endoscopy increases the risk of aspiration because the endoscope probe impairs closure of the glottis and lower esophageal sphincter. This can lead to chemical pneumonitis within a few hours due to aspiration of gastric acid or due to pneumonia several days later due to aspiration of gastric microbes. Patients with bacterial aspiration pneumonia usually develop progressive fever, cough, which may appear chest imaging usually shows an infiltrate dependent portion of the lung, so at the lower lobes. Oh, in the recumbent position, that's why an upper lobe. Posterior segment, dependent segments are the superior portions of the lower lobes. Peptosepticals and aerobes like gram-negative bacilli, streptococcus, and Staph aureus. Yeah, for these aspiration pneumonias, I just think it's always going to be that. So let's simplify it like that so we can remember it. Lung abscess and also to treat aspiration pneumonia. See, we'll edit this card a little bit, send it to wrong questions. Unlock it like that. Okay, perfect. Let's keep going. So now we have a 45-year-old man. He comes to the office for routine follow-up. The patient was diagnosed with hypertension, hypercholesterolemia a year ago. Now takes hydrochlorothiazide and amiloride daily. It's an interesting combination. Like Amiloride is a angiotensin like ACE, no, aldosterone receptor antagonist, and then the thiazide diuretic. Currently feels well. He does not use tobacco, alcohol, or illicit drugs. Blood pressure is 135 over 85. Physical examination is unremarkable. Now his sodium is okay. The potassium is definitely high here. It's like, this could be a combination of this stuff. Obviously, the potassium sparing diuretic. This is just delivering even more stuff over there. Actually, that this thiazide probably not, but the miloride for sure. So no. Now the chloride. Okay, normal, 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 normal. Yeah, maybe a little bit high still, but I think this can cause some higher glucose. There's no emphasis when the blood sample was checked by the laboratory. I think we need to change that miloride, bro. Like, why would we give this guy like the thiazide is not giving him. The thiazide would give him, if anything, hypokalemia because more sodium is delivered to the distal tubule, which would just result in more sodium being absorbed, but at the same time more potassium being dumped out into the tubule. So change amiloride to amlodipine and recheck laboratory results in a week. No, I don't want to change the hydrochlorothiazide. Calcium's fine, bro. Like maybe it's a little bit. No, it's normal. Start introducing dextrose and insulin. I think we need to bring that down. It's like not good. Like it's borderline. It's like pretty high. Like we want pretty tight control of. No, I don't feel comfortable sending this guy back. Like we need to just do it right now. We need to change that. What? Why wouldn't we do that? Okay. How do we define what's mild and like? Well, yeah, I knew that. So I do a miloride potassium strand diuretic that blocks the epithelial sodium channel. Oh, it blocks ENaC, yeah, right, in the renal collecting system. Sodium normally enters the apical end of the principal end. Okay, this creates a negative environment. So we don't be dealing with. Yeah, makes sense. See, this is what we need. This is the piece of information. It's 6.5. That's the cutoff that we're worried, and we should do something right now. Yeah, I mean, I knew that. I'm not gonna unlock any cards. 68-year-old man pulls up to the clinic due to palpitations that have been especially prominent over the past 2 days. Medical history is indicated for myocardial infarction and heart failure with reduced ejection fraction. So that's all going to put him at increased risk. He's now on aspirin, digoxin, not good, furosemide, okay, sacubitril. What I saw it's a classic for heart failure, metoprolol, little beta blocker, and some statins. Okay, he's tachycardic. Physically individual members, the lungs are clear, no peripheral edema is present. ECG shows atrial tachycardia with second degree atrioventricular block. So ECG shows the atrial tachycardia with second degree AV block. Which the following is the most likely responsible for this patient's presentation? think he's being too blocked. Like he's got this beta blocker. Digoxin, I think, causes some heart block. Yeah. Digoxin toxicity can also cause a wide range of cardiac arrhythmias, sinus bradycardia, junctional rhythms, ventricular tach. Although most of the arrhythmias can occur in a variety of clinical settings and are non-diagnostic of digoxin toxicity, atrial tachycardia with atrioventricular block is specific for digoxin overdose and is generally considered diagnostic of toxicity in patients taking the medication. The effects of digoxin toxicity on the heart are complex, but summarized as follows. Atrial tachycardia is likely due to increased automaticity of conduction in the atria. Cool. The focus of increased automaticity may be located within the sinus node, resulting in P wave morphology similar to that of normal P waves, or within another part of the atrial myocardium, resulting in different P wave morphology. The rate of atrial contraction is typically around 200 per minute. Oh, the vagal tone, yeah. We knew that. Okay, let's see what if there's any useful cards for this. Fantastic. I mean, let's just unlock this again. We'll reinforce this concept. Let's keep going. So now we have a 47-year-old man. He pulls up to the emergency department, 3 weeks of malaise, non-productive cough, fatigue, shortness of breath. Could be pneumonia again. Last night he sweat through his pajamas and had to get out of bed to change his clothes. So he's sweating, like maybe some B symptoms. The patient smokes cigarettes and has no breathing. Okay. Farm in rural Mississippi. So maybe the farm stuff. Okay, now he's febrile. Erythematous tender nodules approximately 2 to 3 centimeters in diameter over both shins. So now he has erythema nodosum. Erythema nodosum, Mississippi. Okay, just bilateral. Pachyopasis in large mediastinum. Is this histoplasma again? What the? Yeah. In Mississippi, yeah, the Ohio and Ohio River Valley, Mississippi and the Ohio River Valley histoplasma. Non-caseated granulomas. There you go. So it's not TB. TB is caseated. Sarcoid. Oh my god, this dude has histoplasma. See, aspergillus? No, I mean, it's no. I think aspergillus does form granulomas, but I don't think it has erythema nodosum like that. Coccidioidomycosis does have that, but this guy's not been in those areas. Let's keep this one for now. Hypersensitivity pneumonitis doesn't do this. This is like really bad. It's not tuberculosis. I'm sticking with histoplasma. Mississippi and Ohio River Valley. This patient was treated for pulmonary sarcoidosis with high-dose corticosteroids that are present of erythema nodosum, pulmonary infiltrates, hilar mediastinal lymphadenopathy, and biopsy with evidence of non-caseating granulomas. However, treatment resulted in rapid deterioration of pulmonary status, which suggests an infectious etiology that worsened due to steroid-induced immune suppression. Common causes of granulomatous pulmonary infections include tuberculosis, blastomycosis, histoplasmosis. This patient's vocation as a farmer in rural Mississippi puts him at an increased risk of histoplasma capsulatum, a dimorphic fungus that proliferates in soil contaminated by bird or bat droppings. Histoplasma capsulatum is endemic to temperate areas worldwide, but is found primarily in the central/southern United States and parts of South America, Asia, and Africa. In patients from these regions, pulmonary histoplasmosis should be considered in the setting of community-acquired pneumonia with mediastinal hilar lymphadenopathy, arthritis, and erythema nodosum. Although histoplasma urinary antigen testing is the most rapid method of diagnosis, tissue biopsy is sometimes required. Then he has histopathologic samples may reveal caseating or non-caseating granulomas. Okay. I mean, we pretty much got the gist here. We identified the things we had to identify. Fantastic. Let's keep going. Now we have a 65-year-old woman, recently relocated after retiring, comes to the office to establish medical care. Okay. The patient has a history of hypertension, diabetes. diabetes, hyperlipidemia, osteoarthritis, so the usual. She does not monitor blood pressure at home and reports fair glycemic control with oral anti-diabetic medications. The patient does not use tobacco, alcohol, or illicit drugs and formerly worked as a salesperson in a department store. Now she's 138 over 76. Okay, yeah, she's a little overweight. Cardiopulmonary and abdominal examinations are a remarkable foot examination reveals her third and fourth toes appeared claw-shaped. Third and fourth toes appeared claw-shaped. Dorsiflexion, plantar flexion, dorsiflexion of the proximal phalanges of the metatarsalophalangeal joints and plantar flexion of the proximal appear claw-shaped with dorsiflexion of the proximal phalanges and plantar flexion of the proximal and distal, which of the most likely cause this patient larks. So she has these weird findings on her foot. Interesting. Diabetic neuropathy. Yeah, I don't think diabetic neuropathy is like purely sensory. There's nothing that's not. Foot osteoarthritis with these deformities. I mean, maybe morton neuroma. That's more like when you crack like this sideways, there's like some sort of crepitus sound. I'm not gonna go with plantar fasciitis. No, spinal stenosis, nah. Plantar fasciitis has mainly pain, not these deformities. A neuroma? Dorsiflexion of the proximal phalanges at the metatarsophalangeal joints and plantar flexion of the proximal. Claw-shaped. It's not painful. It's not painful. It's possible that it is a morton neuroma because I think it's the third and fourth. I'm going to go with morton neuroma. Diabetic neuropathy. Hammer and claw toe deformities. Okay, very interesting. That's so interesting. I didn't think of that. I thought diabetes was purely okay. So a lot of things. Okay. I mean, we'll take it. I mean, we probably just didn't know this. There you go. Claw toe and hammer toe makes just underlined it. Okay, let's keep going. So now we have a 43-year-old man comes to the office due to a 6-month history of intermittent upper abdominal pain associated with nausea, maybe some peptic ulcer disease. Dull epigastric pain that are usually worse 50 to 30 minutes after meals and last for a few hours. So if it's worse with meals, it's usually peptic ulcer disease. Then the pain is not relieved with antacids, but improves. Oh, there's a viewer. What's going on? All right. Pain is not relieved with antacids, but improves when leaning forward. That one's interesting. He also has had occasional diarrhea. Maybe some H. pylori. The patient has lost. Oh, he's lost weight. Smoker. Oh man, and he okay, no, this is maybe pancreatitis. He consumes alcohol almost daily. So Pagas cigarettes. I mean, he really, because of this alcohol consumption, it could be either like really bad GERD, pancreatitis, it could be a lot of things. Stop with this weight loss. Celiac? No, this is not celiac. Does he have cancer? This is not mesenteric ischemia. This is not acute pancreatitis. He would be like in extreme pain. Endoscopy, that's assuming he has peptic ulcer disease. But this is like more consistent with this. Consumes alcohol almost daily, bro. Like, I think this dude just has chronic pancreatitis. Yeah. This patient's presentation suggests chronic pancreatitis, most commonly due to chronic alcohol consumption. Chronic pancreatitis typically presents with chronic epigastric abdominal pain that can radiate to the back and is partially relieved by sitting upright or leaning forward. So this is like maybe something different. Patients can have intermittent pain-free intervals lasting from months to a year. Early chronic pancreatitis can present with acute attacks that become continuous as the condition progresses. Patients with chronic pancreatitis develop let's charge this. Should we play some music for the viewers? Okay, there you go. We're charging. We're live. We are live. Okay. Oh, diarrhea, cytherea. Celiac, obviously not. Yeah, this is Courvoisier sign. Great. Okay. I like this. Let's see what the cards are. Oh, we already had a card for that. Fantastic. Now we have a 45-year-old man comes to the office due to exertional dyspnea and fatigue. It could be so many things, maybe heart failure. Patient does spend most of the time indoors because of symptoms. End-stage renal disease due to glomerulonephritis, and 6 months ago he began hemodialysis via arteriovenous fistula. Close to his dry weight, and his hemoglobin has been maintained in the desired range with iron and erythropoietin supplementation. Afebrile, now there's blood pressure. Huge pulse pressure. Huge pulse pressure with exertional dyspnea and fatigue. It could be aortic regurgitation, especially in the context of this guy's renal disease. He's tachycardic. Okay. Distended. There you go. High output heart failure. Displaced. Systolic members heard over the cardiac apex. Yeah, he has some heart failure. Extremities are warm. Most likely cause of this patient's. I mean, this fistula, right? There's a fistula, which is a connection between an artery and a vein. High pressure blood flowing through the artery goes directly into a vein, bypassing capillaries, venules, etc. All of that blood flow is going to return to the heart. You're going to overload the heart with preload. Heart's going to compensate, maybe increase the stroke volume, increase the heart rate a little bit. But eventually that cardiac output won't be able to maintain it. Gets overwhelmed with fluid. Heart failed. Decreased cardiac output. Flail mitral leaflet. No. This is what's going on. Yeah. High output heart failure. Okay. This patient with an arteriovenous fistula has multiple findings suggestive of a high output heart failure. High output heart failure usually involves increased cardiac output in response to a disturbance that causes reduced systemic vascular resistance, such as disturbance with peripheral vasodilation due to metabolic needs. Okay. Hyperthyroidism or severe anemia. Paget disease. Oh yeah. Unable to keep up with Venus return. It's gonna grow out like that, yeah. Should we play some music for the viewers? Yeah, let's play some music. That's too loud. That's too loud. 66-year-old man comes to the office with nausea, loss of appetite, fatigue. Mándalo pa'l carajo que no te va a reclamar. Soltera quiero que estés pa' mi mami, niñecito estás igual, bebé. Aquí estamos tan caras de chinita se me pone cuando con el pasto le da por fumar. Mami, te noto tensa y yo te voy a aliviar. Tú sabes, mami, dale que lo que quieras. Gucci, Prada y cartera. Ella es tranquila, pero encima se acelera. Y tú encima gritando, la noche no está hablando, diciendo que hasta cuando. Sí, I wanna train it, yeah. Como me enamoré de ella. Es que mi sexo la llevo a las estrellas. Mami, no sé cómo me enchulé y contigo. Será esa adrenalina. Okay, so he was getting steroids for the polymyalgia rheumatica, prednisone. Well, the steroids, let's think about it. The steroids, the cortisol axis. Let's see. The steroids are going to go to the pituitary. They're going to block ACTH, so low ACTH. Well, the cortisol is being supplemented exogenously. Definitely not decrease aldosterone because aldosterone has its own pathway. Definitely not decrease aldosterone. El que come callado repite, con ella imposible que me quite. Como le fallaron estas puestas para el desquite. Ella te controla acceso, pero me dio el viper. Estuvo conmigo todo el weekend. Piensa que yo no estoy contigo, porque yo no la sigo, la llamo, no le escribo. Yeah, aldosterone has its own pathway. That doesn't make any sense. Oh man, someone finally getting involved. Joaquin. Well, it just has its own pathway. It's like regulated by RAS more than by this axis. So I think that's the overall thing to know here about this. Seriously, apartment episode of gross hematuria. Right flank pain. Hiking. Heat. And now he's anemic. Vertics are going up. Platelets normal, leukocytes normal. No kidney damage. That's interesting. Is he hemolyzing? pH is low, right? The urine pH. Whatever. Oh, it's acidic. Blood. Red blood cells. Some white blood cells. Huh. What's his vitals like? No. He's not hypertensive. This looks like papillary. No, this is not glomerulonephritis. You would see cast, you would see hypertension, edema. Kidney, like a kidney stone? Increased echogenicity of the renal medulla. The kidney stone won't be painful, like. Although. Oh no, he has. Oh yeah, hematuria flank pain. And he probably passed it, like he didn't. Honestly, that makes sense to me. But like he's anemic as well, like pretty severely. Honestly, I think it's renal papillary necrosis. This dude has sickle cell. This dude has sickle cell. Sand. This patient's gross hematuria with normal red blood cells, no calcium. I'm sure
Ay, Titi me preguntó si tengo muchas novias. Muchas novias. Hoy tengo a una, mañana a otra. Ey, pero no hay poda. Titi me preguntó si tengo muchas novias. Muchas novias. Hoy tengo a una, mañana a otra. Me las voy a llevar a todas con VIP, VIP. Ey, saluden a Titi, vamos a tirar un selfie.
I hate this song.
estoy jangueando en la disco triste. Segunda vez que bailo con otra, pero contigo en la mente. Y esta es la tercera y la última vez que te marco borracho. Es que borracho se me olvida que ahora soy tu ex, que ya te perdí, que ahora el amor de mi vida está con el amor de su vida. Lo siento, pero se me olvida. Y esta cama de ti no me ayuda. Si hubiera sabido que era despedida, tuviera hecho tu madre mía. Pensando que habría sido mejor. Yo ya no espero que me tire alcohol. Que si me encuentras me hace otro maricón. Yo sé que no te regalo caro, ni Gucci, ni Fendi. Yo solo te ofrecía guaro. Pasábamos encima regalando caro. Contigo ya haremos tal y modelo disparo. Yo sigo esperando ese día en el que te encuentres solita de noche. Yo quiero cumplir mi fantasía en el baño de la disco y que todo eso me rebote. Peladito, tú me conociste, hueputa, ¿qué me hiciste? Que ahora bebo y me pongo triste. Si fumo pipi no me río de los chistes.
68-year-old man comes to the office because of diarrhea. For the past 2 months, his stools are post-brand with watery, foul-smelling. Difficult to flush. I mean, there's like sticky. That was my responsibility, guys. And he's lost weight. IBD? 3 years ago. Acute necrotizing pancreatitis. Oh, well, there you go. I mean, this dude just has pancreatic exocrine insufficiency. Malabsorption. You can't absorb fat. Fat has the most calories. Loses weight. This is not responsive to PPI. It's not like it's upper GI, like peptic ulcer disease. Lactose is not lactose intolerance. Fecal elastase. Elastase. This is IBD flare up. No. It's not celiac, bro. This guy does not have celiac. It's the pancreatitis. Fecal elastase is probably one of those exocrine pancreatic enzymes, so I would go with that. Exocrine pancreatic insufficiency. This patient with a history of anecrotizing acute pancreatitis has weight loss, abdominal pain, steatorrhea. His presentation suggests chronic pancreatitis, a progressive inflammatory disease that ultimately leads to pancreatic fibrosis. There you go.
No sé quién la dañó. Ella no era así, no sé quién la dañó. Pero ahora no y lo prende.
El panita, el que vende. Pero un 4940. Muchos de tequila ni lo siente. buena, pero seguro que lo encuentra.
Ella que se siente la presión, ella ni trata y llama la atención. Ey, el perreo es su profesión, siempre cuesta para la misión. Ella que se siente la presión, ella ni trata y llama la atención.
Dude, it's so hot. Okay. 43-year-old, previously healthy man hospitalized due to acute pancreatitis. On day 3, he developed respiratory distress. He's probably has ARDS. He did an I don't know why. This is immediately. Okay, did they give me settings? Okay. His ideal body weight is 70, and we said 6 to 10 is the tidal volume. 6 to 10, so 6 times 70. There you go. Well, they did it well. Breathing normally. Okay, the FiO2 might be a little high. You don't want it above 60%. That's too much. And the PEEP, I'm not sure about PEEP, but you want to keep the airways patent, right? So what is this? Is this still acidemic? Or like, I think it's normal, right? Yeah. That's like it's slightly acidemic. He's appropriately bringing in oxygen, so I'm not going to decrease the PEEP. Decreasing the respiratory rate, that's going to make him accumulate more CO2. The tidal volume is fine. Is that like normal? The concern here, like, you want to correct the acidemia. How do you correct the acidemia? Increase the respiratory rate a little bit. Yeah, right? What? Bro, what? This is ridiculous. Okay, let's see. Oh, there's like a permissive hypercarbia. Oh my god, where is that? Man, where's? Yeah, see, okay. PaCO2 is determined by respiratory. Oh man, see, I'm gonna make a card for this just because I really need to know this stuff. Like, it's like mild. So obviously, in that case, you don't want too much oxygen. It's going to cause oxygen toxicity. Oh, it's under 60. Yeah. So you over oxygenating. 45-36. Bro, that was literally the same. What is it? They throw in that. 34-year-old woman comes to the hospital after a day of sudden onset fever, chest tightness, dyspnea, dry cough. She's febrile, mildly tachycardic, desetting. Leukocytosis. Very mild though. Oh, should have leukocytosis. There's no nasopharyngeal ulceration.
Tú estás con él, pero yo sé que cuando estás en la camita piensas en mí. Y tú duermes con el pensamiento de lo que te hacía a ti. Que no me importa que tú estés con él, mami, vente aquí. Hacerte así, tú estás con él, pero yo sé que cuando estás en la camita piensas en mí. Y tú duermes con el pensamiento de lo que te hacía a ti. Que no me importa que tú estés con él, mami, vente aquí. Hacerte así. Dime si te acuerdas mi vida, de aquel día cuando yo te decía en el oído que era mía. Era sudor y sexo nada más.
Is he getting a man tonight?
Y por la cintura te apretaba, y me te lo hacía, te gritaba, yo te deseaba, y por eso tú y yo te daba, por eso nunca yo paraba. Recuerda aquella noche solo tú y yo sé que te hace falta.
Oh, okay.
No vengas a decir que te hace el amor, si tú
Cardiac
sabes
cath.
que
There
yo
you
te
go.
lo hago mejor. Recuerda aquella noche solo tú y yo sé que te hace falta de mi calor. No vengas a decir que te hace el amor, si tú sabes que yo te lo hago mejor. Tú estás con él, pero yo sé que cuando estás en la camita piensas en mí. Y tú duermes con el pensamiento de lo que te hacía a ti. Que no me importa que tú estés con él, mami, vente aquí. Hacerte así. Tú estás con él.
That's libido reticularis. She has this weird like mesenteric ischemia as well. Renal damage. No, this is just like the embolus from that was like obstructing the coronary artery just went somewhere else. No. Yeah, there you go.
Yo no te he dicho cuántas veces me toco pensando en ti. La noche que pasamos ya la quiero revivir. Invéntate una excusa que vas a salir. Yo necesito pasar otra noche junto a ti. Lo mío es chuparte de la cabeza a los pies. Y sabes que yo siempre te lo hago como es. El hombre de tu vida, tú sabes que no lo es. Yo vuelto como él. Y él no te besa, no te toca, no, como lo hago yo. Y él no te besa, no te toca, no, como lo hago yo. Y él no te besa, no te toca, no, como lo hago yo. Y él no te besa, amor, ni te toca no, pero tú estás con él. Pero yo sé que cuando estás en la camita piensas en mí. Y tú duermes con el pensamiento de lo que te hacía a ti. Que no me importa que tú te comes más y vente aquí. Hacerte así, tú estás con él. Pero yo sé que cuando estás en la camita piensas en mí. Y tú duermes con el pensamiento de lo que te hacía a ti. Que no me importa que tú te pongas mal y vente aquí. Hacerte así. Oye, mami, ven para acá. ¿Sabes que soy yo? Nicky Jam, tu Kaki Music, Radical, Nacho, el de la pauta.
Una pólvora, señores.
Que el amor existe y su poder hace lo que sea. Que cambie de destino y quédate conmigo porque no somos tu idea. Tu amor a la distancia fortalece la confianza conmigo que no lo deseo. Hacia la razón, pero mi corazón va ganando en esta pelea. Y tú recuerdas nuestra parqueado en el mismo lugar donde te conocí. Todo lo que suena en la radio me recuerda. No hay cambio, no sé si pueda ver. Sigo pensando en tu boca, me siento en cuatro paredes. Qué bonito que tenemos en nuestro tiempo, no sé. Y yo tan loco, tan loco. Mirando en tu baile, míralo, ahí siéntete, estoy al oído susurrando. Oh, na, na, oh, na, na, oh, na. Una na, una na, una tan hermosa, en el tiempo no se una na, una na, una na, mira la luna y siente que estoy al oído susurrando, sale contigo, bailando danza al ver aire, y sin prisa yo la mueve, sin tocar nada de mujer, yo hermosa que no sabe, que todo el día lo sabe, y me tiene loco. Con ese baile, sigo pensando en tu boca, me siento en cuatro paredes, junto a la tan hermosa, en estos tiempos no sé, y yo tan loco, sigo pensando en tu baile, mira la luna y siente que estoy al oído susurrando, oh na na, 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 una historia tan hermosa, en estos tiempos no sé. Oh na na, 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 una historia tan hermosa, en estos tiempos no sé.
Hyperosmolar hyperglycemic syndrome, most likely. His calcium's super high. Why is that? I mean, this could be the hydrochlorothiazide. I don't know. Kidney damage. Okay. Urine accumulation. Not really. Normal vitamin D. That's the inactivated version. It's like normal. It'd be the hydrochlorothiazide.
Fin de semana ya te hago, esto no es elevado, no me da lero. Que te pisto por el pariseo, si la mano toda la que se siente incómoda. Yo quería bicho y se lo traje en la boquita como jarabe. Que su contenido quiere que la grabe, como una banger, montate en la cama. Está hecha para ella no es feca, whitey, pantallita en la teta. Caíste yo no fui, pero sé que fue. Los sentimientos secos y la posible. Se monta en el cabello, esto es una reñel. Bebé chupa, ella no es un extrañel. Se lo chupa.
Vitamin D and inactivated vitamin D.
Se el cardio con su trainer. Infraatlantic. La busqué la noche y se montó sin
Would see higher levels.
pero dulce candy.
Would see lower.
Y terminó como Bambi. Está como un angel, es la rengel, más tu morengel. Tú eres de
Lower than higher.
Pa' aprender, esta noche lo cae. Nadie es fiel, con una angel, es la rengel, más tu morengel. Tú eres de angel, pásame el aire. Pa' aprender, esta noche lo cae. Nadie es fiel. Esta super bella que anda buscando un superhéroe, que la supervisa mientras se toca en el mueble. El mueble lo siento porque no se mueve. Está buscando que yo su contacto en la remueve. Tú eres ángel como vela, mami, yo te diga vela. No quiere a nadie, pero me considera. Si viene a verme, llega en ropa ligera. Yo no mandé a tu amiga que te dijera lo rico que se sentía. La tomando energía, la güey que trae una perla, pero se sentó en la mía. Le gustan los tríos y la alegría. Que somos una pornografía, que sea una trilogía. Y yo brillo tanto que ya ni me veo. Entra tan lista de deseo. Es que quiero más que señalarte con los dedos. No importa el signo, igual yo te leo. Ay, aquí no hay agua, pero toma, ay, coja, esta por no Pero regresa cuando vuelvan. A los focos que nos fuimos hasta un forro cochino. Porque encuentro en la alfombra que yo voy a ser coladino. A la madre de los vecinos, a la paga los bombillos. Que me informan que por ahí vienen los polis de camino. Y no queremos que se nos apague la noche así, bebé. Voy a seguir revisando que eres mi por la mano en la pared. Eres mi por la mano en la pared. Por la mano en la pared. Por la mano en la pared. Eres mi por la mano en la pared. Ando en una Bengal, en la Rangel, no tú eres Engel. Engel, pásame en el lighter, que quiero prenderlo y la noche es loca. Nadie quiere.
I'll take it. It's not bad. My fellas, thank you so much for joining me. We'll see you in the next session. It's pretty solid. Peace.